flu season has started, and so I thought it was good to have a refresher and remind you what we're doing in the trial. As I said, a chance to ask questions as we go along. Either you can write them in the chat or ideally put up your electronic hand because it's difficult to see everybody at the same time. Happy to answer them. So, and for those who don't know me, I'm Tony Gordon. I'm the Chief Investigator in the UK for REMAP CAP. Thought we'd start with a study update to say how things have been over the last couple of years recruiting in flu. We have a total of 66 sites actively recruiting right now. A few sites that are open but sort of dormant. But as you can see, we've recruited around about 400 patients with flu, mostly adults, but it's great that we have pediatric recruits in the platform now. And close to around about 400 patients. I think I noticed one recruit just now before I came on. So the numbers are going up right now. And so I think it's sort of 11 patients recruited just in the last month alone. So as I said, flu is starting. And globally, remembering REMAP CAP's international, we have over 800 flu patients recruited. So again, half the patients are coming from the UK. And we're focusing on flu right now. But just to point out, the REMAP CAP platform recruits other patients other than just flu. And about 1,400 patients have been recruited over the last year. So REMAP CAP is still a very active platform for all types of community-acquired pneumonia, viruses, bacteria, etc. There are a few amendments going through and including the substantial amendment 43 is just waiting for that HRA final approval before it comes in with some updates really on some of the documents. But the team will, the rest of the trial team will talk about that in a moment. What I thought I would do is just show you about the recruitment and call out some excellent recruitment. Milton Keynes has been astonishing in its recruitment with over 100 recruits in the last couple of years, which is just amazing. So well done if you're on the call, the Milton Keynes team. And then obviously, my own hospital is St Mary's, but others, UCLH, St Thomas's, Paul, Portsmouth, Middlesbrough. I won't read the list off, but I'm glad there's a great spread of recruitment across the sites. And you can see that recruitment. We're focusing on the flu recruitments, which are the dark blue is the antivirals. Good number of steroid recruitments, and there is a little bit in some of the antibiotic domains. So that's what we've been doing over the last few years, and it's continuing. And what I wanted to just there's an outline of things we're going to touch on briefly. As I said, I'll get straight on because I want a chance to have discussion, answer questions, and so on. So just to remind you that REMAP CAP is an international adaptive platform trial for severely ill patients, i.e. in hospital with community-acquired pneumonia. For that, it's global, and in order to run it, there are regional sponsors at different places around the globe. So we're still part of Europe, and UMC Utrecht, or Utrecht itself, is the center hub. As you'll see, there's a slight change in the sponsor details, but it's still based in Utrecht, the same team. And that allows us to have recruitment from around the world. There are, I think it's around 300 sites in different places around the world. And you can see all the regions there. A lot is going on in Europe. It's a big hub, obviously Australia as well. And in Europe, Lenny Durde and Mark Bonton are the European leads. And as I said, I lead it in the UK. But importantly, we have the trial team who do all the hard work. And you hopefully will have had contact with different people over time, but you can see their smiley faces here. So you know who you're dealing with. Steph is obviously a little bit camera shy. We don't have a picture of them. So the design, just to remind you, it's a platform for community-acquired pneumonia of all sorts. And then within the platform, we have the different domains, which are should be almost considered like individual trials within the overall platform. So we have platform eligibility criteria, which I've just run through, and then patients will meet the different inclusion exclusion criteria for the different domains, which, as I said, is essentially its own trial. So there's a control group in each domain, and you've then got the active intervention. So you can see the antiviral domain, the steroid domain, and the immune modulation domain. I'll go through those details, but essentially for flu here, there are almost 3 different trials going on at the same time. That's what gets us the efficiency, but it's also multifactorial. We're testing, we can look at the interactions between the different interventions as well. It's also a Bayesian adaptive trial. So that means that there is no fixed sample size. We keep on enrolling until we meet predefined thresholds to declare a drug is beneficial or equivalent, or even potentially harmful. So just to explain how that works, if we put a figure up, the whole Bayesian approach, this works with a prior probability that something might work. And we use, when a new intervention comes in, we use a weakly informative neutral prior. And that's sort of here, you can see it on this graph. You've got odds ratio of 1 is no effect. And then the way it was constructed, we show benefit with the odds ratio greater than 1 is odds of a better benefit, or -1 would be harm. So this is weakly informative. It's likely is the drug may have no effect, most likely, or if it does, it has a weak positive or negative effect, and it's unlikely to have a really big effect on outcomes. You then generate the data. We run the regular adaptive analysis, and as information accrues, you change the distribution of the probability of the benefit or harm of the drug. So here you say a little bit more information now about the patients randomized. We've got data emerging, and it's suggesting, okay, it's possible that there's some benefit. You enroll more patients, you get more information, and you become a little bit more certain about the effect of the drug. And the idea is we keep going until we get a clear signal. And as you can see here, that this is the posterior probability distribution. So we said you start with a prior, you update it each time with more data, and you get a posterior after your analysis. And if the probability here, as you've seen, is greater than 99% that the drug is working, we would stop and say this drug is of benefit. For the sake of time, I won't show all of the different criteria, but you could equally say, well, if we've got thresholds for saying, well, if it was harmful, we would stop, or if in fact 2 drugs were equivalent, we would stop as well. So just a little bit to explain the design, which we think is a neat design and gives us definitive answers. A little bit to say is, again, we started with REMAP CAP about 9 years ago, studying bacterial community-acquired pneumonia. We obviously pivoted in the pandemic to COVID-19. And we've always had influenza there in the background, but it's very much come to the fore in the last few years, particularly in the UK with the NIHR funding, setting us up as the national influenza platform in the UK. And we call all of these different disease pathogen groups strata. So these are different strata within the platform. And we, for instance, analyzed COVID separately to the others in the past. We have other strata and disease states. So within influenza, for instance, different patient strata is considered adults and children. And we also divide the children into those greater or less than 12 years of age. We actually analyze the adults and the over 12s together because we think their outcomes are more likely to be similar, and the younger children get analyzed separately. But obviously there will be different approaches to how we might recruit between the 12 and 18-year-olds. So that's why they are a separate strata, but we group them together in an analysis. So that's the strata because they are fixed at the time of enrollment into the trial. But then we also have disease states, and these can potentially change over time. That's why we don't call them strata, they're states, because they can change the state of the patient. And essentially we say what we call the severe state is essentially critically ill patients, that the patient is in ICU receiving respiratory or cardiovascular organ support. They're critically ill. Everybody else we say is not critically ill. We term them in the moderate state. And so that's all other patients. And again, the way the analysis works is they can be analyzed separately, but also if the effect in these different states is similar with the dynamic borrowing we have within the Bayesian platform, they can be brought together. So again, to be efficient and get as much information from the different patient groups as possible within the study. So it's only pedantic terminology, but often people say, oh, the influenza domain. Actually, it's an influenza stratum within the platform, because the domains talk to those sort of almost individual trials. So actually refer to the different therapeutics that we are testing. So we'll go through what those domains are in a moment. But first of all, we'll just say that eligibility for the overall platform is quite simple. Just to say you're eligible, or patient is eligible for this if they're either adult or a child, 28 days or older for the corrected gestational age, so not neonates, but any other pediatric cases that are in hospital, either on the ward or the ICU, because of an acute illness due to respiratory tract infection. So as I said, any bug that's causing that acute illness, a respiratory pathogen. The exclusion criteria, again, relatively simple. We want to get people in a timely way. So we say they have to be within 2 weeks of their hospital admission, or if they're in the ICU at the time of recruitment, within 48 hours of the ICU admission. We don't want people who are basically too sick to benefit. So we say that is when death is imminent within the next 24 hours, and both the team and the patient are not committed to full active care. So essentially, if you're in a palliative care pathway, you think the patient is actually dying. Or equally, we don't want to recruit patients who are already getting better and about to go home. So if they're going to go home within the next 24 hours. But in both groups, it's unlikely any of our treatments are going to modify the outcomes. So that's why we exclude too sick or too well. And you can only be in the analysis once, obviously. So our primary outcome includes up to 90 days. So can't come in twice. So then we come to the individual domains, which, as I said, are then specific criteria for the different interventions we're testing. And so the ones relevant for influenza are the influenza antiviral domain. The only additional inclusion criteria here is the patient has to have a confirmed influenza infection by any means, any sort of microbiology testing, lab, point of care, it doesn't matter, just that they tested positive for the flu. And we again want to try and treat these patients as early as possible, because if we think if they've been ill for too long, it's unlikely the antivirals are likely to have an effect. So if they're in the moderate state, the non-critically ill, it's within 96 hours of hospital admission. Or if they're in the ICU, within 48 hours of their ICU admission. So that's the time base. We want to treat people early in the disease. We also don't want to include people who've already been treated with antivirals, because again, it's unlikely that we're going to have any beneficial effect if we just add them on after already being treated. And so we say if the patient has already received 2 doses of oseltamivir, i.e. a day's worth of the drug, they would be excluded. Or baloxavir, as it has a longer half-life, then only just 1 dose counts as already be treated. So we exclude those patients. Obviously, if they're allergic to any of the drugs, they can't be included. And pregnancy is an exclusion just for baloxavir. The way our system works up, it being adaptive and dynamic, if the patient was pregnant, they can be randomized oseltamivir versus control. They can't be randomized baloxavir versus anything else. So baloxavir would be excluded. So you can still include pregnant patients, but they would only be eligible for the oseltamivir or control intervention. The steroid domain, corticosteroids, has slightly different inclusion criteria. We want the patients who need any form of supplemental oxygen. I think the evidence suggests that if you don't have the pneumonitis and don't need oxygen, you're unlikely to benefit from steroids. So we only want those patients that are slightly sicker. We're running the steroids domain not just in flu, but obviously we're talking about flu today. Time-wise, if they're coming to the ICU, they're already in the ICU, so the critically ill patients, it has to be early in their ICU admission. So within 24 hours of ICU admission, getting people early, again, we think that's where the patients will benefit most. they can't be randomized if they're getting steroids for any other reason. So they're already on steroids, or you're planning to give steroids for a non-influenza pneumonia cause, then they can't be randomized. And obviously, allergies, as always, unlikely to be allergic to steroids, but if they were. And so for the immune modulation domain, which is for ICU patients only, so extra inclusion criteria, they have to be critically ill on that organ support. And we're only running this, again, a bit like the antivirals, but only running it in flu patients. They have to have a confirmed influenza infection. We already know these drugs work in COVID, so COVID is an exclusion, for instance. We have some other exclusion criteria. It's not all definitive. You can look them all up, but the big key ones are if they're immunosuppressed, if they've got active TB or invasive fungal disease, they're already receiving immunosuppressive therapy, either other IL-6 blockers or JAK inhibitors, or they're allergic to any of the interventions. And the pregnancy is, at the moment, is the pregnancy. We're still just clarifying that around trying to get patients eligible for the tocilizumab intervention. And so just to go through then what those interventions are, that I've talked about the different domains. So with the antiviral domain, it's the two antivirals we're testing are oseltamivir or baloxavir, or the combination. And obviously the control group is no antiviral. The steroid domain is no steroids as the control group. And the main steroid we're testing, particularly for influenza, is dexamethasone. For those doing it in ICU, there is still hydrocortisone for the shock-only patients, but that's only for the ICU, not for the ward-based patients. And the immune modulation domain, as I said, only for those in the critically ill population, the severe state. We're testing the IL-6 inhibitor tocilizumab and baricitinib, a JAK inhibitor, again, both immune modulators that were shown to be beneficial in COVID. And so again, taking these sicker patients with influenza that may have a lot of inflammation, we think there's potential benefit there. And we're glad that we've recently got the new supply of tocilizumab from Roche. Its contracts are all signed. We're just finalizing the ordering process. And again, the team will identify how you order that as it comes online. So in order to get started, here's a list of the various things you need to have at your site, the right amendments. You have to choose which of those domains you want to open and which interventions you want in, appropriate training. As I said, you can see the oseltamivir, dex, and baricitinib is from hospital stock, but the baloxavir and tocilizumab can be provided to your sites free of charge. They'll be sent in centrally, and the email address is there for you to contact the team. And what I will do is just stop temporarily and see if you guys have got any questions at the moment. Now I can see you could see. So Nazima, you've got a question.
Sorry, I was trying to unmute myself.
No worries. Hi.
Just for clarity, for some of our new doctors, we have got new doctors in our team and staff as well since our last recruit. So TTOs, am I correct in saying we are not the responsible people? Our doctors are not responsible to prescribe the TTO unless the treating clinician wants them to continue. They prescribe that. Am I correct?
So TTO, you mean to take away from the hospital? Yeah.
Yes.
Yeah. So the protocol is for inpatients only. So if the patient goes home, they can stop. Obviously, if they were on a prolonged course and going home before the prolonged course, I didn't go into the detail of all the interventions and how long they all were for. But particularly if they were on the long course of oseltamivir, the protocol says you can stop it when they go home. If you want to continue it, you can. That would be outside of the protocol, but that's fine. What we would ask though is if you're on the short course, not to obviously extend it when you go home. That's the whole point. If it's only the standard 5-day course, not to
Yeah.
extend that one. But you can write that, but we don't mandate that because we know it would be very difficult to sort of run a CTIMP both in the hospital and out of the hospital at the same time. So we stop. And assuming they got better if they're going home.
Yeah. No, it's just that because we've had a case with that, but the patient did go home with baloxavir. They were prescribed both. So baloxavir, we are still responsible to prescribe for the patient to take home.
Yeah, because they're unlikely to be able to get it from any other source. So if your clinicians wanted to do that, they're free to do it. It's not
sometimes the patient is discharged within the next day. So of course, if they're taking it for 4 days.
Yeah. Well,
they can.
They don't take it every day. They just take the day on day 4. Yeah. Just I thought that was what you meant, but I didn't want anybody to get the wrong idea. Yeah.
Thank you for clarifying
No
that.
problem.
And the oseltamivir, if it's being prescribed at a short dose, but their treating clinician wants them to continue for 7 days, that's still okay. But the treating clinician is still responsible for prescribing the medicines to take home. That's the bit I wanted to clarify.
Yeah, we would discourage that because the protocol says it's for 5 days. That is the standard treatment.
Yes.
And so we would encourage everybody to stick to the protocol. That's why we're testing 5 versus 10 days. And if everybody gives 7 days, then the more people who give 7 days, the less likely we're going to get an answer. There has to be separation.
Yeah.
5 days is the standard recommended course. So we would really encourage people to stick to the protocol. Obviously, clinicians are responsible for what they prescribe, so we can't stop you. You must do what you think is right for the patient, but that would be a protocol deviation and needs to be recorded. If your sites keep on doing, your investigators keep on doing it regularly, then that would be a concern, and we may have to consider whether your site really has equipoise to randomize. But so try and encourage them to really stick to the protocol so we learn what is the right duration, whether it's 5 days or 10 days. Thanks.
Okay, thank you very much for clarifying those.
Okay, no worries. Gemma, I think you've got your hand up.
Yeah, thank you. It's just 2 really quick ones. I did some training the other day, and because of the way our site is kind of more of a tertiary centre, if a patient comes and we get a result from another hospital, can that be used?
Yes.
If it's not from ourselves?
It can, if it's come from another hospital, if it's relevant for this admission, that test can be used rather than repeated. If you know that, it was done in the other hospital, we came here, there's no need to repeat it. That counts. Yeah.
Amazing. And would a transfer back be classed as, especially if the other hospital isn't doing REMAP CAP, would a transfer back to a local hospital be classed as almost like a discharge? And so we wouldn't have the medication follow them?
Ideally, if you can arrange that they follow the same protocol, because these are drugs that we use all the time. They, particularly the steroids, the oseltamivir. I'm looking to the trial team, but certainly in COVID, we have permission to move drugs. I know regulators, MHRA, don't normally like IMP moving between sites. But as this is baloxavir is being used for flu, which is in its marketing authorization, and it is not research only stock, I think you could move it with the patient. But if you can't move it, again, we're not going to count that as a protocol deviation. But obviously we would like people to get treated as close to the protocol as possible. But if it's not possible, then they just can't follow that same thing, allocation. Does that make sense? Try your best.
Yeah.
Yep.
Yes. No, perfect. And one last silly thing. just because of how our clinical trial pharmacy works, if they're randomised to the baloxavir arm, how long have we got to get that dose in them?
As quickly as possible. I mean, and I don't know if we, again, I'll look to the team to shout if we specify. I think we may say ideally, but again, if you can't meet it, try and get it in as quickly as possible, because I realize they may not prescribe it until the following morning, I'm guessing is what you're thinking.
Well, the prescription wouldn't be a problem. It would just be getting it out of pharmacy, because at our site, our clinical trials pharmacy are holding it. It's not going on the ward. It's being held by them.
I should
sadly.
I might ask Aisha if there a time frame that we sort of ideally like.
Yeah, we try to say as soon as possible, ideally within 24 hours. I think there have been a couple of occasions where sites have not been able to give it for whatever reason until a day later. So what we've said is to count that as day one, and then count the days from then onwards, so that it's not that you're giving it on day 2 and then you give the day 4 dose 2 days later, but you'll count that first dose as day 1, and then so there'll be the same gap between the time points. Yeah.
Okay, no, that's perfect. It's just that if we get a randomization at 6, 7 o'clock at night, we wouldn't be able to get our hands on the dose until like 9, 10 o'clock the next morning.
Yeah, understood. Yeah, that's it's fine. It frustrates me that we can't treat patients quicker because of regulation for drugs that are very safe in this population, that we have to keep them under lock and key. But I keep battling to try and get things easier so that we can do reflect more like normal care.
Yeah, no, I think it's just in pediatrics, our clinical trials pharmacy are always a little bit more overcautious.
Okay.
Thank you so much. Thank you.
Are there any more questions before I go back to Catherine?
Hi, thank you. Can I just ask another question on baloxavir? One of the most recent amendments mentions baloxavir granules. The only information that's present about that is a label, I think. Can we just ask when we'd expect any more information on the baloxavir granules to come through? Things like administration's instructions and, because we'll need to update our e-prescribing.
Aisha, do you want to take that? This is obviously for pediatrics.
Yeah. So the stock of granules is not available yet, unfortunately. I think Roche said sort of mid-November. We do have a pharmacy manual that is currently in draft, but the sponsor have requested a few sites to sort of check it over to see if it makes sense. I can actually send it to you if you'd like to review it as well.
Yeah, draft version would be great, just to get ahead of the curve on kind of e-prescribing builds. That would be really helpful.
And then once we finalize it, hopefully very soon, then we'll send that to the sites as well.
Brilliant. Thanks so much.
Okay, great. Nazim, I'm assuming that's a legacy hand rather than a new one, but if it's a new one, shout.
Sorry, was that question to me? I didn't.
Yeah, your hand is still up. I assumed it was an old hand rather than
a new one. It's an old hand. I do apologize. I'll take it down.
No worries. I will go.
We do have a question just from Ashley in the Q&A chat. She just asked if we could provide an updated letter from CMO. She said it really helped to show clinicians that it's ethical for participating sites to recruit patients to the control group.
Okay, I can ask. Is there? Do you think an update like it will say the same thing? Can we not use the same one? It's just trying to, although I'm happy to write to Chris Whitty, he's a busy guy, and I just wonder, can we use the old one? We also have the letter from Lucy Chappell, I think from last year. So the first year, Chris wrote it. We've got this CSO, and then we've got the CSA, Chief Scientific Advisor, Department of Health, Lucy Chappell. I would encourage, to show those. I can ask if we can get a new one. I will. Let's see, but it may take a little while. Fair enough. Okay.
I'll reshare the slides.
Okay.
Just make it easier. Can we see that?
It can, yep.
Perfect. So I'm just going to go through some eligibility and consent reminders. So in June, we provided sites with an eligibility checklist and consent statement. This is optional for sites to use. It's more just for their help. They can use their own template, or they can just write this information directly into the medical notes. And then just to remind you of the consent process. So once a patient is identified as being eligible for the study and satisfies all inclusion and none of the exclusion criteria, their capacity should be assessed. If they have capacity, informed consent is to be obtained and then the patient randomized. And if there is not capacity, then you should check if per-LR or parent is available. If yes, you can obtain consent and then randomize. And then if no, you should check if per-LR is available. If per-LR is available, then you could randomize, and then you should obtain per-LR/parent consent as soon as possible. If a per-LR is not available at the time, you should randomize and obtain at least per-LR consent as soon as possible. You should always ensure patient consent is obtained and as soon as possible once capacity is regained. And you should always document all conversations regarding consent in the patient notes. And if necessary, you should file note and store in the ISF. If it is not written down, it did not happen, and all patients and families must be aware of their inclusion. So just to go through some of the current consent documents. So in regards to localization, we will provide sites with a Word document where the treatment sections will be adapted and locked by the management team. And it is the site's responsibility to add their trust header and local contact details. We realise this has changed from last time, but it's just to make everything a bit time efficient and also make sure that the correct treatments and interventions have been selected and aren't missed off. We also now have translated PIS documents. They're available in 8 languages. We did reach out to sites recently to ask which languages they would like. We are waiting for Amendment 43 to be approved, and once it is, we will send both the localized English documents and the translated documents to sites. And then just a reminder of the documents that are available for the trials. So we have patient and parent consent, per-LR, pro-LR. We have summary versions, there's telephone consent and video consent, and the privacy notice. And just for screening reminders, so you should complete screening and an enrolment log on either paper or a spreadsheet. You should confirm eligibility with a doctor and document in the source medical notes. You should enter eligibility patient into the ECRF and go through the full digital eligibility assessment. And the subject will then be randomized, or if it is a screen failure, they'll be moved to the registry list. If consent intends on being collected but not obtained, do not enter no for consent and rather save the ECRF, and you can complete the rest later once consent has been obtained. If you select no for the consent, it does not prevent randomization. It assumes delayed consent is being followed and it will randomize the patient. So I'll just pass on to Aisha.
Lucy, just before you do that, I saw there were a couple of hands up.
Oh, of course. Yes, sorry, I can't see those.
Have we got the right order? I thought there were 2. I can only see
it's 2 names, but I think it's 2 names under one camera, maybe.
Hi, Lucy. Yes, just clarify with regards to the video or the summary informations when we're approaching for consent. Of course, do they have, at that point, if they just go through the video, for example, can they, when you say video consent, do you mean like there's a videos they watch, or remind me again?
Yes, of course. So we created a video consent to make it easier for patients who were unable to read the full document, and you can find this on our website. And then there is a separate video consent form which should be signed once this video has been watched. And
with regards to then the full PIS, I mean, obviously we still issue these. They can consent just with the video consent, and then we issue the full PIS and they can always go with that. But we don't necessarily have to have them read the full PIS.
Yeah, that's correct.
And with the summary as well, does that apply for the summary or not?
Yes, it does.
It does. Okay, fine.
Yeah.
Thank you.
Yeah,
Thank you.
that's it. We want to inform patients appropriately about it when they're unwell, recognizing they can't read all of it at that time, but they have the full information available to them. I can now see who the other person was. It was Emma. Emma, did you have a question as well? We can't hear you if you're talking. Can't see you, obviously. So. You're on mute, I think. Maybe not.
Is there anything in the chat maybe that's
If you want to put it in the chat, Emma, we'll carry on and see either in the Q&A or and we'll come back to it. We can't hear you if you are talking. Unfortunately, can't see you either.
Okay,
So carry on. Why don't you carry
yeah.
on and we'll see if we can answer Emma's question if she writes it down if we can't hear her.
Okay, so we'll just go on to a few of the other procedures. I think I've got control of the slides. Oh. No, it doesn't. Oh, it's just being a bit slow. So we're just going on to the IMP. So we've listed the various IMP for the various domains here. And a lot of it is from hospital stock, and we would just follow the routine procedures for ordering, labeling, storage, and temperature monitoring. Where it's highlighted in red, it's where we have study-specific supply. So as you can see, that's for baloxavir and tocilizumab. And we have study-specific order forms for those. And then again, for temperature monitoring, tocilizumab and baloxavir, we can use the clinical trial pharmacy temperature logs. If you have your own sort of electronic systems, that's fine. I think it's tocilizumab that's kept in the fridge. So if you don't have like a automatic system, then you can use our trial-specific temperature logs for those. With accountability, we only require pharmacy accountability for baloxavir and tocilizumab. We don't collect ward accountability. And then for the hospital supplied drugs, it would just be your routine logs, whatever you have. So no study specific logs are required for those. Again, for destruction of stock, we have trial specific logs for baloxavir and tocilizumab, and it would be routine local destruction procedures that are followed for oseltamivir, baricitinib, and all the other hospital supplied drugs. So yeah, we don't have study specific logs for those. Lucy, could you change it to the next slide because it's not letting me do it, even though I've got control. Thank you. So updated documents. We have the pharmacy guide, which will be coming soon. And then apart from that, we have updated pharmacy accountability logs, as I mentioned, IMP destruction logs, so that you may have old templates, but we've now got all these updated templates. And then the IMP order form is also a new version of the form. We will ask you to complete your details and then we will sign it, and we then put your order onto the electronic system that we have access to. And following that, I think we will send a acknowledgement of receipt form to sites. If you could fill that in and return it to us once you receive the order. Next, just a quick reminder about SAEs. So we are only reporting related SAEs to the study or interventions, and those that are specified in the domain-specific appendices. We do require the initial report to be done within 24 hours of site staff being made aware, and then follow-up and final reports can be submitted with further information thereafter. Everything's entered on the database and the PI signature as well. We do have a backup paper form, but that's only if the system is down. Quick reminder about nasal swabs. So there's 3 time points where nasal swabs need to be collected for patients that are flu positive. It's day 1, day 3, and day 7. We provide sites with the kits, so if you have run out, if you can send us a request. We usually provide 5 patients worth at a time, so three sort of green tubes per patient, and then 3 swabs per patient for the 3 time points. And we also provide the barcode sample labels, as well as the safe boxes with the lab return label on it. So yeah, I think we sent out quite a few packages to sites recently. If you did send a request in, if there's any more sites that need materials, do let us know. At the moment, we've got a bit of a delay with the green tubes from our supplier, so it may be a few weeks before we get those. But in the meantime, it shouldn't prevent recruitment. We still want sites to recruit, as this is more for secondary outcomes. We have updated our electronic training log. So if you remember previously, we had a training log for each training module on our website. So we've now updated this so that there's only 1 log, and on that log you can select all the modules that you have gone through. Hopefully this will mean that we receive less emails and you have to fill in less forms. So yeah, that's something that we've improved.
Aisha, can I just ask you a question that's been asked in the chat from Ashley? She's asked her to remind us if those clinicians confirming eligibility need to complete a GCP or not. Am I right? It's just they need to complete the eligibility assessor training on here.
Yeah. So we have the eligibility assessor module, and within that module, there is a quick slide about the basic principles of GCP, which is sufficient for the role of eligibility assessors. And then we don't need to collect a CV either, because once you select eligibility assessors on this log, another field will appear which will ask for GMC number, and we just need to collect that, and that would be sufficient for eligibility assessment.
Thanks. And just Ashley and others, we're trying to make it as simple as possible. MHRA insist that we must have training for people assessing eligibility, but we don't think they need the full GCP, but they need the relevant training for that criteria, and they do have to be medically qualified by GCP ICH requirements. So hopefully that's a simple approach for those people.
So they do have to be listed on the delegation log. It's just that we don't need the CV or GCP. They just need to do this smaller training module and complete this training log.
I can see there are probably some other questions, but later we'll go on and then do it in case there are other topics. So we'll come forward for the other points that have been raised in a moment. I'll let you carry on, Aisha. Thanks.
Yeah, I think we've only got a few more slides. So just talking about how we share REMAP CAP awareness amongst non-study team at sites. We've sort of given a few tips to sites, but we just wondered whether anyone wanted to share anything else that worked for them. We do provide posters, and we've sort of suggested that you could put these by the rapid test machines or around the wards. Or I know some sites have maybe regular meetings with their doctors. It sort of varies from site to site. We recently wanted to email sites individually to ask if perhaps they can set up the email that comes from the lab team, which would normally inform the clinical team of a flu positive patient, if perhaps the research team could be copied into that email alert so that they're made aware that, you know, there's a potentially an eligible patient for REMAP CAP. Or I don't know if there's a way of perhaps incorporating an alert on electronic medical notes once the patient is flagged as being flu positive. We understand that like not everyone's in control of their electronic systems, and IT might take time to do things, but I guess it's worth exploring these different things. I don't know whether we have specific comments about that, or Tony, did you want to add anything?
No, just to say, I mean, I think we're just trying to raise awareness. I think one of the commonest reasons for excluding potentially eligible patients that have already been treated with antivirals. And so it's sort of to try and incorporate into your systems, is there a way to flag the patient for potential research as well, including in REMAP CAP at the same time as, so for instance, the IPC team usually get an email to know they need to go in a side room. At the same time, could it say, and consider them for REMAP CAP, flag it to the research team, for instance, so that then at least those conversations can happen before the patient is treated. And I just reiterate the reason we're doing the swabs is to look for potentially development of resistance, which can happen with antivirals. And there's concern, obviously, that if these drugs aren't effective, and we're just giving them anyway because they're relatively safe drugs, and people say, well, what's the downside of just giving everybody oseltamivir or baloxavir? They could develop resistance, and we've actually just had one flagged to us recently. So I think going back to the comment about convincing clinicians that it's okay to randomize patients to the control, they're part of the reason, not the only reason, but part of the reason you don't want to give patients drugs they don't need because they all have smaller side effects. But if all we're doing is making resistance in our sick population and they're not getting any benefit, we're just storing up trouble for the future when these antivirals don't work against flu. So I'll put that forward. Why don't we just do the last couple of slides and then take the slides down and have 10 minutes of Q&A. I think we've just got a couple more.
So just a quick note about funding. We've had a lot of queries because we know that the last extension is sort of coming to an end at the end of this month. But the NIHR have agreed to extend until the end of next year. We're just waiting for the letter to come through before we can submit it as an amendment and then disseminate to all sites. We've also we've completed the first part of the application for pandemic preparedness, and that's currently under review. And that would be to extend from the end of 2026 for another 5 years. And that's it. So I think we can probably go to questions now.
Yeah. Should we go to Emma's mate? Emma Moxis has got a microphone working. So why don't we, Emma, you put it up ages ago. Why didn't you come in first?
Mm-hmm.
Emma, are you there? Emma Mox? Maybe your microphone's still not working. So, Emma, why don't you try and write it in the chat? And I think as anyone, we'd love to hear you, but we just can't, unfortunately.
Yeah, she said in the chat it's not working.
Oh, it's not working.
Yeah.
I've read it's now working. Okay, but all right, let's go. Let's do what people got their hands up. I think it says it keeps it alternating. Mohammed and Amelia.
Right, thank you. This training log, electronic training log, would we get a notification? That's the thing. The key is that if people are completing it, especially on the critical care and that, there's loads of staff. So we just want to know how we kind of gather this.
So you would get an email confirmation, and then we actually ask for that email confirmation to be forwarded to us because we need proof of the training as well. So you definitely get an email that confirms that you've completed
so the
training.
person completing it, but those who maintain the ISF, the question is all the log. That's the key. So do we chase the person? We chase the person.
So that everyone else won't get a notification. It will just be that person that receives the email confirmation. So they would have to forward it to whoever's in charge of keeping the ISF up to date.
Okay, fine. Also, I'll notice that, for example, with regards to training, like the antiviral domain for, I think it was at 2.2 last time, and it's 2.3, but I can't see any difference. You know, the online training, sometimes it changes. The header changes.
Yeah, so it changes when we update the actual page. So it might not be that any of the materials have changed. It could be that we've updated the online page and we just need to sort of version control that.
Okay, so this is my point, is that if I was trained on 2.2, for example, then do I chase people to train on 2.3?
No,
No, okay.
it would be fine. Yeah. We would
Fine.
let sites know if there were any major changes. We would then let sites know and request for everyone to recomplete the training.
Okay, yeah, that's fine. And just to go back on regarding the template for the domains, we edit this, correct, for our particular site for the eligibility. You know, there's a template for different domains when we do
Yeah. So that is,
screening.
Yeah, you
So
can edit it. So you can remove the domains that your site isn't taking part in, or we can do it for you. But yeah, you can definitely amend that template.
Okay, thank you. Yeah.
While we're talking about training, I can see Ashley had wrote about the paper training log. Is that still usable, or is it only the electronic one?
Yeah, that's still usable as well. If that's what you prefer, then that's totally fine. We can just make sure that everything's up to date on the website in terms of the paper forms.
Okay. And then I can see in the chat that's been sent, Emma's obviously can't get her microphone working, so she's written an email and it says asking if the consent statement is mandatory or optional, if they create their own history sheet covering the statements that are on there. I presume
Optional. Yeah. So again, it's just a template that we created because several sites asked if we had a template, as some sites have their own template, some don't. So yeah, it's optional, much like the eligibility statement. If you have your own templates, that's totally fine to use.
and then one I can take quickly. Ashley again asked if there are updates from the data monitoring committee. I know they met, I forget whether it was June or July, that they met in the summer, and obviously that's the Australian winter for the recruitment down there, and they had no concerns, no results yet, and advised the trial to carry on as already. They a new adaptive analysis, interim analysis, has been sent to them in October. I think they're due to meet November. Obviously, if there is any information from that other than carry on, we would of course let you know. But just so you know, the data monitoring committee are looking at the data. And then Nazima had a hand up.
Oh, hi, yes. Coming back to your training log, is it an individual process to fill this out, or am I getting it wrong?
The electronic log, it would be on an individual basis.
Okay.
If you wanted your whole team to just sign one log, then that would be the paper log.
Okay.
You can use whichever one you find more suitable.
Okay. Thank you.
Okay. Maggie looks like next.
Yes, sorry. My internet is playing up a little bit, but when you showed us how we can spread the word about REMAP CAP, you said there can be posters and a few other things. I took a picture of the slide, which was really good. Are you able to provide us with these posters that we can put in our areas where people are seeing patients?
Yeah, sure.
And
We
said
can
share newsletter. Do you have a one-page like brief newsletter that we can share? Because this window we want to do well, we want to recruit, and it's sort of the sort of study that some patients would be interested in. But obviously, it's very difficult to just find a one-page brief overview of what we're doing for patients to look at and get a good buy-in. Thank you.
So would the newsletter be for staff or for patients?
So post that definitely for all working areas for patients to see and some staff to be aware. The newsletter for staff, just to encourage them so that they know what's happening. And I was thinking once we've done that, then we can do the brief meetings that you're talking about, because we'll have new F2s joining, I think around December. And the current doctors, we can continue doing more awareness. But I thought we could try and tap into all three. I mean, you've put 5 options, but we can tap into at least 3 of these.
Sure.
Yeah.
We can definitely provide the poster, which is aimed at staff. We do have a patient leaflet, but I think that needs updating. So we will probably need to update that. But if in terms of a one-page newsletter, I think our newsletters tend to be longer than that, but we can definitely look at producing a one-page newsletter
Yeah.
to make it short and sweet.
Yes.
Yeah, so we can work on those.
Thank you.
And then I think Gemma, we haven't heard from Gemma. She had a question.
Yeah, sorry, it's just a bit of a strange one. So we at the Royal London in Peds are open to all arms in the antiviral, including no antiviral. If we have a patient that gets one dose, obviously technically they're still eligible, but would they not be for us? Because obviously we're open to that arm, because our PI is querying whether we shut to that arm, if that's going to prevent some patients being recruited.
So it works for the whole domain. So one dose, so if it was one dose of baloxavir, if they've already had one dose of baloxavir, then they're excluded from the whole domain.
No, it'd be the oseltamivir.
So that's fine. If they've had one dose, we don't consider that treated. So they're still eligible.
Okay.
They then get randomized to whatever option they get, which could be control if you're then doing all arms, in which case you would have to not give any more oseltamivir, and we would consider that patient, no antiviral.
Amazing.
Yep, no, so that's it. And it would work across the whole domain. So even if you're not doing baloxavir, for instance, like it would still always, or even not doing oseltamivir, which is unlikely that, I think we don't allow you to not do oseltamivir. But yeah, it covers the whole domain, because if you're already treated with antivirals, the chances are we can't show any difference between any groups, because everybody's been treated.
Oh no, we were just worried because we were open to the no antiviral. If they'd had just one dose, that would still exclude them. No, that's amazing. Thank you.
Thank you. We're trying to be pragmatic and practical. Emma's asked a question, and I will look to the team to make sure I don't again say the wrong answer, because I know we've discussed these things before. Are advanced practitioners allowed to confirm eligibility, or does it have to be medically qualified? We don't want to fall foul of the regulations.
So what we said was that anyone who has prescribing rights, which I think does include at least some practitioners.
I thought that was right. Our rationale being, if they're making the decision to prescribe the drug, they can assess the eligibility, that they're suitable for the drugs and randomized. That was our rationale. I thought it was, but I didn't want to say the wrong thing and get us all in trouble. But hopefully that answers your question, Emma. Thank you.
It does. And I think my mic is working. Thank you. Sorry, I'm so sorry about that. I think I needed to be unmuted from your end.
All right.
So yeah, I came across the eligibility checklist and statement earlier on today. And that's why I sent the email before the webinar, actually, and then you just answered it. So thank you, but you did also answer it when you were talking. So I've come across it, and you've just said it's optional, so I don't think we're going to use it, because all of the stuff that no, sorry, not the eligibility one, that's the consent one. We're not going to use it because all the stuff is covered in our history sheet anyway, which is fine. So I saw the eligibility checklist and statement, which we weren't currently using this specific one, but we will be now. I found it. Because on the top of there, it does say the clinician is defined as any role who has the prescribing rights. It says it on there. So from today, am I okay to update the practitioners about that and get them involved, because they've been so keen to be involved and disappointed that they've not been able to do eligibility?
Definitely. They would just have to complete the eligibility assessors module and the training log, but it's a pretty short module. You could print it off if you wanted to, and if that's easier. And it's just, I think, about 5 slides, and then there's the electronic training log or paper log if you think that's easier.
The eligibility slides, is there a newer one then? Because I've got the older one that's probably about 20 slides long, with the little bit of GCP incorporated in that.
I'll double check on the website if I think it's a version 1.2.
Okay.
So it might be that you have the old versions. But
Okay.
I'll have a look at that.
Great, thank you, and sorry about that before.
No, that's okay. I think we just have Nathan in the chat is just asking, is it possible to send an updated version control log? I'm assuming you mean the sort of document version tracker. We can send that. I think it's on the website, but I'll just check if it's up to date, and we can send that. Or if you meant something else, do let us know.
No, it was the document version control log. It's just there's been that many updates since I've started the post, so it's just so they can get our site file sorted.
Yeah, that's fine.
Thank you.
Any more questions? Oh, sorry, there was one from May. I presume that's May from Imperial. One May, I think we should talk and try and see if there's time for the medical staff to train. Come and have a word with them. I don't know if anybody else has got an idea of if they're finding it difficult speaking with the resident doctors who may be doing these assessments. If they've got any ideas how to involve them. Nathan, are you answering that or different?
Yeah. Sorry, I was answering that.
Please do.
So our intensive care, they do bi-weekly education mornings with all of the medical staff that are in the unit, and I just find it best to ask to take one of those mornings for half an hour to speak about research, especially whenever there's new staff coming in. So we've got a rotation of doctors changing in the next month, and I'm gonna ask to speak at one of those mornings so that right at the start we can get them interested and hopefully get them involved in the studies that we've got in the unit. So find out what the education rotation is like and see if you can get involved.
Sounds like a good idea.
Yes. Yeah, thank you. We do that already. The problem is the people that you have trained, you can almost guarantee that when that one patient's admitted, none of them are going to be on duty. And it's how you quickly address the training for the junior staff at that time, so you don't miss that patient.
If I think so, we had some sites that had a similar issue, and what we suggested was that they could print the eligibility assessors slides with a training log, so that if on the spot there were no doctors available, so they needed somebody for eligibility assessment, they could quickly read through those printed slides and sign the training log there and then they'd be able to do eligibility assessment. Just because I think people are finding it difficult to actually get them to do the training beforehand by email or whatever. I don't know if you think that would work, and then a copy of the delegation log as well, so that they'd sort of sign everything at the same time there and then on the spot on the unit.
Yeah, I mean that's what certainly we have done in the past. Yeah, so we will continue pushing that, and hopefully, I think as more studies are developing this style, it is becoming increasingly difficult at times. I mean, yes, if you can get into the training, it's fantastic. You can get a lot of them trained in one fell swoop, but it's just, recognizing that is a need on a daily basis now. I think it's becoming slightly more difficult.
There's always new challenges, May, and I think there's never one approach that answers. We have to take a multi-pronged approach to tackle these things. So I appreciate the shared learning. If anybody's got ideas, do let us know. We'll try and share them around and so on. We'll sort of just aware of time, and we run over, but it's great to have questions and discussion. If people want to head off, please do. I mean, we've got nothing formally to present, but equally can stay on a line for if anybody's got any other questions people want to ask. But I'd just say thank you very much again for your support of the trial and recruiting the patients already. As we said, flu seems to be coming a bit early this year. It doesn't mean it's going to be bad, but it could be. But let's be ready to include more patients, and hopefully we'll get an answer soon. 800 patients is a large trial. I think it's probably the largest in-hospital patient trial now. I'm trying to remember, most of them are only 400s in the past. So well done, everybody.